Welcome to the Bariatric Surgery Program at UAB. We're a comprehensive adult center with the Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program. Let me introduce you to the Bariatric Surgery team. This is Dr. Stahl speaking. I'm the Medical Director of Metabolic and Bariatric Surgery. I earned my MD at UAB, completed my general surgery residency at Caraway Methodist Medical Center in 1994, entered private practice in the Birmingham area for the next 16 years, and came to UAB in 2010. In addition to weight loss surgery, I've got a strong interest in surgical education, and I've performed over 3,000 bariatric surgical procedures over my career. Dr. Jayleen Grams earned her MD and PhD at UAB and completed her general surgery residency at the Mayo Clinic in Rochester, Minnesota in 2008. She did a fellowship in minimally invasive and bariatric surgery at Mount Sinai Medical Center in New York City and came to UAB in 2009. In addition to metabolic and weight loss surgery, Dr. Grams performs advanced minimally invasive surgery for diseases of the esophagus and stomach, and she is the chief of surgery at the Birmingham VA Medical Center. She has performed over 1,000 bariatric procedures. Dr. Kristen Wong completed her undergraduate studies at the College of William and Mary. She attained her MD at Virginia Commonwealth University before doing her general surgery residency in New York at Montefiore Medical Center. After completing her minimally invasive surgery fellowship at the University of Wisconsin, Dr. Wong joined our practice at UAB in 2022. In addition to her expertise in bariatric surgery, Dr. Wong also performs minimally invasive surgery for diseases of the esophagus and stomach and advanced endoscopic treatment of those same diseases. Our clinical nursing staff includes Chrissy Lundeen. Chrissy coordinates care of the patients in the clinic, and she's the primary contact person for patients who have clinical questions or are in need of instructions in the pre- or post-op periods. Bree McGriff and Meredith Andrews are both certified registered nurse practitioners. They assist seeing patients in the clinic, and they do the lion's share of short and long-term follow-up of the bariatric patients after surgery. All bariatric surgery patients begin their journey with our colleagues in the UAB Weight Loss Medicine Clinic. This is where your first appointment will be. Their staff of physicians specializing in metabolism and obesity, along with dietitians and behavioral specialists, will obtain a medical and dietary history, begin the education process so important for successful bariatric surgery, and perform lab work required prior to treatment. The Weight Loss Medicine Clinic helps patients navigate the often lengthy process of obtaining pre-certification for bariatric surgery. That process may take 6 to 12 months depending on each patient's insurance policy. Marie Stoves is the bariatric coordinator for UAB. Marie is the liaison between the bariatric surgery program at UAB and the MBS-AQIP, or MBS-AQIP for short, our credentialing body. Marie also coordinates the weight loss surgery support group meetings, Fresh Beginnings, and she facilitates post-operative education of the patients while in the hospital. Brianna Irvin is a clinical reviewer for UAB. As a comprehensive center with the MBS-AQIP, all patients undergoing bariatric surgery at UAB are entered into a national database where outcomes are tracked and compared with other centers. Brianna is responsible for collecting and entering that data. Now that you know who we are, let's spend a few moments discussing obesity, bariatric surgery, who it's for, and who it's not for. So let's first define a couple of terms. Bariatric surgery is the surgical treatment of a metabolic disease known as morbid obesity. But morbid obesity is not the same as simple obesity or being overweight. There are varying degrees of obesity, and we categorize those by a measurement called the body mass index, or BMI. The BMI is basically a weight to height ratio, wherein a patient's weight in kilograms is divided by their height in meters squared. A normal healthy weight is a BMI between 18 and 24. Persons are considered overweight if they have a BMI between 25 and 29, The diagnosis of obesity begins at a BMI of 30, and we call it Class 1 obesity if the BMI is between 30 and 34. Class 2 obesity then corresponds to a BMI 35 to 39, and Class 3 obesity, sometimes referred to as morbid obesity, begins at a BMI of 40. For over 30 years, recommendation for bariatric surgery was guided by a 1991 National Institute of Health Consensus Conference. It stated that any person who had a body mass index of 40 or more should be considered for bariatric surgery if they were deemed healthy enough to undergo surgery and had failed prior attempts at weight loss. In addition to that patient population, patients who had a lower BMI, 35 to 39.9, should be considered for bariatric surgery if they also had medical conditions thought to be due to obesity, such as type 2 diabetes, obstructive sleep apnea syndrome, or hypertension. Age was not specifically designated, but bariatric surgery was generally performed only on patients 18 years of age or older. Since 1991, the operations done for obesity have changed. Surgical techniques such as laparoscopy and robotic surgery have emerged, and the safety and efficacy of bariatric surgery has been extensively studied and improved. So, in 2022, the American Society for Metabolic and Bariatric Surgery, ASMBS, and the International Federation for the Surgery of Obesity and Metabolic Disorders, IFSO, published new guidelines on indications for metabolic and bariatric surgery. Metabolic and bariatric surgery is recommended for individuals with a body mass index greater than or equal to 35 kilograms per meter squared, regardless of presence, absence, or severity of comorbidities. Metabolic and bariatric surgery should be considered for individuals with metabolic disease and body mass index of 30 to 34.9 kilograms per meter squared. Due to genetics, the prevalence of diabetes and cardiovascular disease is higher at a lower BMI in the Asian population than in the non-Asian population. Therefore, metabolic and bariatric surgery is recommended at a lower BMI threshold, 27.5 kilograms per meter squared, in that population. Because obesity is a chronic health condition, like diabetes or hypertension, the longer one has it untreated, the worse the implications of the disease. Bariatric surgery has been studied and shown to be safe in appropriately selected adolescents, so it is now recommended to consider bariatric surgery in those patients. However, UAB is an adult comprehensive bariatric surgery center. We do not currently perform bariatric surgery on patients under the age of 18. However, while the indications for bariatric surgery have changed, most insurance providers have not, and still largely adhere to the previous guidelines. Change is slow. Some patients may have class 2 or 3 obesity but still not be considered candidates for surgery. These are called contraindications, and they include patients not healthy enough for major elective abdominal surgery, patients with a past surgical history and perhaps adhesions or scar tissue that would make bariatric surgery impossible or too risky, patients who are deemed not psychologically fit for bariatric surgery, non-compliant patients, and patients with a history of substance abuse or ongoing substance abuse. I'll spend the next few minutes explaining basically how weight loss surgery works and briefly describing the procedures we do at UAB. The gastric bypass is one of the two most common procedures done for weight loss. The stomach is first divided into a very small upper pouch, which is separated from the remainder of the stomach. The pouch is roughly 1 to 2 tablespoons in size, or approximately 1 ounce. The small intestine is then divided downstream from the stomach. The distal, or far end, is elevated over the stomach and colon and attached to the small stomach pouch. The proximal or near end of the small bowel reattaches to the remainder of the small intestine about 3 to 5 feet downstream from where it was initially divided. After the operation, when a patient eats, the food, which appears blue in this animation, passes into the small stomach pouch, then into the intestine. bile and digestive enzymes from the pancreas, which appear green in this animation, flow through the other channel to mix with the food after it has passed 3 to 5 feet downstream. From that point onwards, digestion and the flow of food is normal. Sleeve gastrectomy is a newer addition to bariatric surgery, but one that has become quite popular in recent years. Using a series of linear surgical staplers, the stomach is divided and sealed. Approximately 80% of the stomach is removed, leaving a sleeve of stomach, roughly the diameter of the esophagus, which is the tube that connects the mouth to the stomach. This decreases the capacity of the stomach to hold food and thereby restricts the volume of food that can be consumed at one meal. Unlike the gastric bypass, however, the full length of the stomach is retained, preserving the muscular valve at the bottom of the stomach, the pylorus, which slows food emptying from the stomach, but food, bile, and the digestive enzymes still follow the normal route through the GI tract. Exactly how each of these operations work is still a bit of a mystery and an area of active research, but the primary goal of both operations is to decrease the amount of food and calories a person eats. The sleeve gastrectomy and gastric bypass both seem to decrease appetite. While it's not known how this occurs, theories are the operations somehow counteract certain gastrointestinal hormones that increase appetite and help other hormones which decrease appetite. The net effect is patients tend to be less hungry. Some physicians also feel the gastric bypass causes malabsorption, that is, it decreases absorption of the food that is eaten. However, that's probably not true. The intestine is a very efficient organ, and even though a portion of the intestine is bypassed, most of the digestible calories consumed are absorbed from the GI tract. There is, however, some decreased absorption of several vitamins and micronutrients with the gastric bypass. There are risks inherent in any operation. Each of the operations we're discussing are major surgery, and they share at least the following potential complications. These include, but aren't limited to, bleeding, infection, injury to other structures, blood clots, anesthetic complications, conversion from laparoscopic to open surgery, development of gallbladder disease in 10 to 15% of patients, malnutrition, pneumonia, hernias, and death. Those are risks that can occur with either operation, but there are also risks somewhat unique to each specific operation. For instance, leaks from the staple line can occur in 1 to 2% of sleeve gastrectomy patients. A leak can be a severe and life-threatening complication which might require reoperation, placement of stents, placement of drains, prolonged restrictions on eating, and other possibilities. A stricture occurs if the stomach passage is made or becomes too tight for food to fit through. It might require endoscopic stretching of the stomach, or even surgery to remove that portion of the stomach or convert the sleeve gastrectomy to a gastric bypass. And 15 to 20% of sleeve gastrectomy patients may develop gastroesophageal reflux disease even if they didn't have it prior to surgery. Similarly, the gastric bypass has some risks and complications unique to it. Like sleeve gastrectomy, leaks can occur with gastric bypass at a rate of 1 to 2%. These can be very serious complications, and they might require reoperation, placement of drains, stents, or other interventions to treat the problem. Ulcers occur in 5 to 15% of individuals. Certain factors are known to increase the development of ulcers, such as smoking and use of non-steroidal anti-inflammatory drugs, including ibuprofen, Aleve, aspirin, BC, stand back, or Goodies powders. We advise against the use of these medications in patients undergoing gastric bypass surgery. Most ulcers can be treated with medication and stopping the smoking and the use of those medications known to cause ulcers, but some ulcers may require surgical treatment. Stricture, or narrowing of the anastomosis between the stomach and intestine, occurs in 3 to 5% of patients. The same activities that lead to ulcers can also cause stricture. Treatment is usually endoscopic dilatation, meaning stretching of the narrowed area with a balloon dilator, but it could require surgical revision of the anastomosis, and that is more difficult and risky than the original gastric bypass procedure. Intestinal obstruction due to adhesions or an internal hernia may occur often months or even years after the original bypass. It typically requires surgery to fix it. Vitamin and/or micronutrient deficiencies can occur with any of the operations, but they're more common with the gastric bypass. And dumping syndrome we mention not because it is a risk per se, but to explain the phenomenon. Dumping syndrome describes the constellation of symptoms patient will experience if they eat or drink sweets. You see, sweets, sugar that is, are easily absorbed by the intestine. Sugar requires no further digestion or breakdown to be absorbed. Prior to gastric bypass, sweets that we eat are held in the stomach, diluted, and gradually released into the intestine. It exits the stomach through a muscular valve at the bottom called the pylorus. But the pylorus is bypassed with gastric bypass surgery, so there's no mechanism to slow the exit of food and sweets from the stomach. Sweets are dumped into the intestine, drawing fluid rapidly into the intestine to dilute the sugar. This rapid fluid shift causes bloating, flushing, palpitations, nausea, and discomfort, usually within minutes of eating. The symptoms are called the early dumping syndrome to distinguish it from the late dumping syndrome that we'll talk about in a moment. Over the next 30 minutes to an hour, the patient may gradually feel better. However, recall that sugar requires no digestive enzymes to be absorbed by the intestine. Consequently, the blood sugar rises very quickly after eating sweets, causing the pancreas to release insulin. But the pancreas often overshoots its mark and drives the blood sugar down too low, causing the patient to feel terrible again, usually an hour or two after the ingestion of sweets. Thus, counter to what many patients think, the ingestion of sweets, such as soft drinks, fruit juices, candy, or desserts, don't improve hypoglycemia. They actually cause it. This effect is called the late dumping syndrome, and the patients that experience it will usually choose to avoid the types of foods that cause it, sweets, which is exactly what we recommend. All surgery carries risk of death and complications. These are considered major abdominal surgery, and while great strides have been made decreasing the mortality and morbidity of bariatric surgery, risk still exists. The risk of death from gastric bypass is approximately 5 out of 1,000, and the risk of death with sleeve gastrectomy is about 4 out of 1,000. The risk of a major complication from either operation is about 5 out of 100. To put this in perspective, however, the mortality from more familiar operations is also listed. The risk of death from an appendectomy is about 1 out of 1,000, and the risk of death for a patient undergoing gallbladder surgery is about 3 out of 1,000.
However, we also know that the risks and outcomes of surgery vary for different individuals. Some patients may have higher risks or lose more weight than other patients. But utilizing outcome data from the Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program, we can now more accurately predict the risk of complications for each individual patient based on their unique characteristics, such as height, weight, and health conditions they have going into surgery. At the time of each individual patient's initial surgical consultation, we will review the complication rate of other patients in the database who are similar. We will also review the average weight loss those patients achieved over 1 year.
How do the operations compare in terms of weight loss and improvement or resolution of obesity-related health conditions? More studies are coming out comparing weight loss results of sleeve gastrectomy with gastric bypass, but it's important to remember the sleeve gastrectomy is a newer procedure, so we have less long-term data on it. One of the better studies was performed at the Cleveland Clinic and published in the New England Journal of Medicine in 2014. It was called the STAMPEDE trial, which is an acronym for Surgical Treatment and Medications Potentially Eradicate Diabetes Efficiently. They randomly assigned 150 patients who had both morbid obesity and poorly controlled diabetes to one of three treatment arms. 50 patients received intensive medical therapy, including medication, as well as diet and exercise counseling, but no surgery. Another 50 patients received the same medical, dietary, and exercise therapy as the first group, but also underwent gastric bypass. And 50 more had sleeve gastrectomy instead. After 3 years of follow-up, this is what was found. This first graph demonstrates weight loss as a function of the change in body mass index. The top line represents those patients who did not undergo surgery, while the bottom two lines represent sleeve gastrectomy patients and gastric bypass patients. You can see that both operations achieve far greater weight loss than diet and exercise alone. You can also see that the weight loss results from gastric bypass are marginally, but statistically significantly better than sleeve gastrectomy. Besides losing weight, bariatric surgery hopes to improve patient comorbidities, that is, other obesity-related conditions such as diabetes, sleep apnea syndrome, hyperlipidemia, and high blood pressure. The graph shown is from the University of Michigan. They compared the resolution rates of those conditions for patients in their state undergoing bariatric surgery with one of three operations: gastric bypass, sleeve gastrectomy, or adjustable gastric banding. Each of the triple columns depict a medical condition associated with obesity. NIDDM, or non-insulin dependent diabetes mellitus, sleep apnea syndrome, IDDM, or insulin dependent diabetes mellitus, hyperlipidemia, and hypertension. The leftmost of the three columns depicts gastric bypass. The middle column is sleeve gastrectomy, and the right column is adjustable gastric banding. An asterisk at the top of the column indicates the difference between it and the center column is statistically significant, that is, not presumably due to chance. Looking at the first two diabetes columns, we notice that gastric bypass was statistically significantly better at resolving diabetes than sleeve gastrectomy in the middle column. And sleeve gastrectomy was statistically significantly better than adjustable gastric banding in the right column. Same is true for hyperlipidemia. Looking next at sleep apnea syndrome and hypertension, we find that both gastric bypass and sleeve gastrectomy were statistically significantly better than banding at causing resolution. But the difference between bypass and sleeve was not significant. In other words, they were roughly equivalent. Interpreting this, we think more research needs to be done. But might there be an advantage that gastric bypass has over sleeve gastrectomy in the treatment of diabetes and hyperlipidemia? To help answer that question, in regards to diabetes at least, we can refer back to the STAMPEDE trial. A primary goal of this study was to determine if patients with poorly controlled diabetes would achieve better control of their diabetes with the addition of bariatric surgery of either type versus intensive medical therapy alone. A secondary goal was to see if there was a difference in the degree of control obtained with sleeve gastrectomy versus gastric bypass. If you're diabetic, you're probably familiar with a lab test called hemoglobin A1C. This is also called glycated hemoglobin. It correlates with the average blood sugar sustained by a patient over the preceding 3 months. For instance, if a patient has a hemoglobin A1C of 6.0, their average blood sugar over the past 3 months was about 120. This graph shows the improvement in hemoglobin A1C in the 3 groups of patients in the STAMPEDE trial. The top line shows the improvement obtained by those patients who did not have surgery. You can see it's not nearly as good as the improvement enjoyed by those patients who underwent sleeve gastrectomy or gastric bypass. However, the difference between gastric bypass and sleeve gastrectomy is not significant, indicating both operations on average
achieved substantial improvement in diabetes control, much better than those patients who didn't have surgery. But we can't say that one operation achieved better control than the other, at least not based on this graph. But look at this next slide. This graph compares the number of medications required to achieve the improved diabetic control in each group. As expected, the patients who did not have surgery required the most medications, and the groups of patients who underwent surgery required significantly fewer. But comparing the results between the two types of surgery, sleeve gastrectomy required modestly but significantly more medication to achieve the same level of diabetic control as the gastric bypass patients. So how do we summarize this information? Gastric bypass has been around longer than sleeve gastrectomy, and we have more and longer-term data on it. But sleeve gastrectomy is the most commonly performed weight loss operation in the United States and the world. The average weight loss for gastric bypass is more than sleeve, but usually only about 14 to 18 pounds more. Both operations help diabetes. Gastric bypass may achieve that with slightly fewer medications, but it's also a more difficult operation to accomplish. It does have a higher complication rate, and it probably causes vitamin and micronutrient deficiencies more commonly. So we can't say that one operation is better than the other. There are pros and cons to each of the operations, and neither is perfect. Patients can do very well with either, but may also be unsuccessful with either. The operation is primarily a tool. It's largely up to you, the patient, to use that tool to adopt a good, healthy diet and exercise habits that you'll have to maintain for the rest of your life. Neither operation will prevent you from regaining weight if you eat too much and don't exercise.
So now that you hopefully have a better understanding of bariatric surgery, the goals, the risks, and how the operations differ, let's talk about the process forward. If you'd like to learn more or make an appointment, go to our website by typing UAB Medicine Bariatric Surgery into your search engine, or call 205-934-7053. Insurance coverage for bariatric surgery varies greatly from company to company and even within companies depending on the policy. You're encouraged to contact your provider and specifically determine if weight loss surgery is a covered benefit. If so, what's required of you to qualify? If not, is paying for it out of pocket a viable option? Plan to attend one of our support group meetings. It's a requirement to attend at least one meeting prior to surgery. All patients begin the process for possible bariatric surgery with the UAB Weight Loss Medicine Clinic. Prior to obtaining insurance pre-certification, all patients will have a lab panel drawn. This is typically done at the time of your first appointment with the Weight Loss Medicine Clinic. After your evaluation by the Weight Loss Medicine Clinic, an appointment will be made for you to see one of the surgeons. The surgeon will review your medical and surgical history and determine your suitability for bariatric surgery. They will also review the procedures, the pros and cons of each, and help you decide which of the procedures you would like to have or what might be best for you and your circumstances. Patients desiring a sleeve gastrectomy will have an upper GI, also known as an esophagram, wherein you'll be asked to drink some contrast while x-rays are done to look at your esophagus, stomach, and swallowing mechanism. Patients desiring gastric bypass will have an EGD scheduled to look inside the stomach, specifically the portion that will be bypassed to assure that there is no worrisome pathology in that portion that might need to be addressed. Because once the gastric bypass is done, there is no easy way to examine that portion of the stomach in the future. Depending on your overall health, your past medical history, or your insurance company, you may also be required to be seen and cleared for surgery by other physician specialists.
Obesity is the number 2 leading cause of premature death in this country. Smoking is the number 1. Insurance companies and we require you be completely tobacco and nicotine free for at least 2 months prior to surgery. This includes smokeless tobacco, electronic cigarettes, nicotine patches, gum, and other forms. If you are a current smoker, tobacco user, or nicotine user of any sort, we require at least 2 negative consecutive monthly nicotine tests to prove complete cessation. Some patients may be required to have a psychologic or psychiatric evaluation prior to surgery. All patients must go through nutritional and dietary counseling with our dietitians. Many insurance companies require proof that the patient has been continuously morbidly obese for 3 to 5 years prior to the request for bariatric surgery. This usually necessitates records from the primary care physician, wherein the patient's weight has been documented. If those records aren't available or weights weren't recorded, some insurance companies will consider dated photographs of the patient going back the required amount of time, which visibly document morbid obesity. Insurance companies generally won't consider letters from a physician simply stating the patient has been obese for that period of time. They want proof. Risks of complications and death associated with surgery increase with the weight of the patient and the associated comorbidities patients have going into surgery. For this reason, we will require some patients to lose weight prior to surgery, often 10% or more. The UAB Weight Loss Medicine Clinic is an excellent program to help achieve that. On the other hand, even if we don't require a patient to lose weight prior to surgery, many insurance companies require patients to participate in a physician-directed or supervised weight loss program prior to consideration of surgery. If so, that diet must usually be 3 to 6 months long, include behavior modification, dietary counseling, and documentation of physician visits, often monthly. Also, that diet usually has to be done within the previous 12 months. Physician-directed diets done longer than 12 months ago generally don't qualify. We strongly recommend researching the particulars of the insurance-mandated diet if your insurance policy is one that requires it. Many do, but not all, and the specifics of how it needs to be done varies considerably between policies. If a patient diets but doesn't do it in the manner prescribed by their policy, their insurance company is unlikely to approve surgery. The preoperative diet requirement of many insurance policies is usually the most time-consuming portion of the hurdles a patient must clear prior to pre-certification for surgery. Policies are vastly different in what they require, and policies change their requirements periodically. In general, though, if a preoperative diet is mandated by your insurance plan, 3 options usually exist to meet the requirement. Your primary care physician can administer the diet. If that's done, however, he or she must include dietary counseling, behavior modification, and exercise therapy. Simply directing you to eat less or handing you a 1,200 calorie diet sheet is insufficient, and you could expect your insurance company to deny weight loss surgery. In addition, you must see your primary care physician monthly, and the physician must appropriately document all that is being done for you. You may choose to join Weight Watchers or a similar type program to achieve the dietary counseling, behavior modification, and exercise therapy components of the mandatory diet. In that case, your primary care physician must see you at least every other month and document that you're participating in that program and your progress in the program. Online programs aren't sufficient. It must be a program with weekly meetings that you have to attend and keep a record of that attendance. Our recommended path for patients with an insurance company mandated preoperative diet, however, is referral to the UAB Weight Loss Medicine Clinic. This is a clinic run by doctors with expertise in metabolism and nutrition. They have considerable experience in helping patients complete the preoperative diet requirement.
Once all the preoperative requirements of the program and the insurance company have been met, the UAB Weight Loss Medicine Clinic will submit a request to the insurance company for pre-certification for weight loss surgery. Assuming a favorable response, we will contact you and decide together on a good date for surgery. We'll ask you to come back to our clinic one more time so that we may update your medical history and physical exam, complete any preoperative admission tests that need to be done, sign papers, undergo pre-anesthesia screening, and answer any additional questions.
4 to 6 weeks before surgery, all patients must complete the Bariatric Surgery Nutrition Education class. There is an additional $100 charge for this program, and it is mandatory.
The class will cover the preoperative diet. It begins 2 weeks prior to surgery and is a protein-sparing, very low-calorie, low-carbohydrate diet with the goal of losing weight, lowering blood sugar in diabetic patients, and shrinking the liver, which is often enlarged in obese patients and gets in the way of the stomach. Patients will have to purchase some meal replacement products for those 2 weeks, and those choices will be discussed during class. Patients will also be educated on the diet progression after surgery, which we call phase 1, 2, 3, and 4 diets, as well as lifelong restrictions and vitamin supplements. It's very important not to eat any solid food after midnight before the operation. You will receive instructions regarding which, if any, medications and/or liquids you may have the morning of surgery. You'll be asked to arrive several hours before the anticipated start time of your operation, which usually lasts 2 to 3 hours. After the operation, you'll go to the recovery room, usually for 1 to 2 hours. Then you'll be transferred to a hospital room. The morning after surgery, you'll have an upper GI X-ray to check for leaks and the integrity of the newly fashioned stomach. Once that is okay, you'll be offered a clear liquid or phase 1 diet for a day. If that is tolerated, diet is progressed to food of a thicker liquid or pureed consistency, phase 2, for the next 2 weeks. Then soft food, phase 3, which we describe as fork tender meats and foods you could eat if you didn't have teeth, for 8 to 10 weeks. Then a regular diet, phase 4, starting about 3 months after surgery. Most patients go home 1 or 2 days after surgery.
After discharge, patients are usually seen again in 2 to 3 weeks, then at 3 to 6 month intervals the first 1 to 2 years, then annually. Labs are checked every 6 to 12 months the first 2 years, then annually thereafter. Successful weight loss surgery requires drastic, lifelong changes in patient behavior and eating. The typical diet is roughly 400 calories per day immediately after surgery, but gradually will roughly triple over the course of a year. When patients are consuming so few calories, it's easy to become protein deficient. Thus, protein becomes the most important component of a meal, especially during the most active period of weight loss. It is necessary sometimes to take a protein supplement. Sweets and calorie-laden beverages should be avoided. Patients should take very small portions, turn off the TV and any other distractions, sit down to eat their meals, take very small bites, and chew their food very well. Exercise is extremely important to maintain weight loss. At a minimum, patients should do at least 4 hours per week of aerobic exercise. All patients require vitamin supplementation. There are numerous ways to get these vitamins and numerous brands. They don't require a prescription. We recommend at least 1 multivitamin with iron daily, a sublingual vitamin B12 supplement daily, and a calcium plus vitamin D supplement such as Citracal twice a day. It is imperative that you never smoke or use tobacco or nicotine products. All of these increase the risk of ulcers and complications. Likewise, we strongly recommend avoidance of non-steroidal anti-inflammatory drugs, also known as NSAIDs, such as ibuprofen, Aleve, Advil, Mobic, Goodies powders, BC powders, or Stanback. These are all known to increase the risk of ulcers and stricture. Tylenol or acetaminophen on occasion is okay if taken as directed. Many obese women suffer with infertility, but losing weight may increase fertility, in other words, increase a woman's chance of becoming pregnant. However, we strongly advise against pregnancy during the period of time patients are losing most of their weight, generally for the first 1 to 1.5 years after surgery. During that time, it's very important to use birth control. We're pleased and excited to take these first few steps of a lifelong journey with you. The decision to undergo weight loss surgery is not an easy one. and we think it requires careful and thorough consideration. Please jot down any questions you have, and we'll be happy to answer them. Thank you for choosing UAB